We're honored to have our 2024 Pathfinder, Dr. Tarek Bismar. Here we are in 2025, it's not even over. And by July, if you check PubMed, you will see that Dr. Bismar has been cited in 6 published articles. So we want to thank the Prostate Cancer Centre, who worked with Dr. Bismar to free up some time in his schedule to spend with us tonight. In preparation for tonight's presentation, I thought I would do a little research on my own. And so, like many students today, I immediately went to AI. And it provided me with the following definition for PARP inhibitors. PARP inhibitors are a targeted therapy drug that blocks the enzyme poly, ADP ribose, polymers, which again comes the initial PARP, which helps repair DNA damage in cells. By preventing cancer cells from repairing their DNA, these drugs cause the cells to die, leading to tumor shrinkage and preventing growth. AI kept going, but I stopped because I got lost. So I'm eager to learn more, and I'm sure Dr. Bismar will be able to help us to understand how these PARP inhibitors work and what their common uses are and how they're advancing prostate cancer treatments.
Thank you, Brad, again for the introduction. It's a pleasure to be back. Sorry not to be there in person. So I'm not in Calgary, that's why the good weather, but hopefully I'll be able to present to you some background information about PARP inhibitors and the role that they play in prostate cancer and a few other cancers for treatment. So today I'm not going to be talking much about my research, but just a general information about PARP inhibitor. All right, so just an overview. I'm going to be talking about what PARP inhibitors are, how they work, PARP activity in cancer cells, potential synergies with other cancer therapies, and response to PARP inhibitors by specific cancer type, because they're not really only specific for prostate cancer, but for other cancers as well. And then at the end, I'll just briefly discuss some safety and potential side effects of those drugs. So how do PARP inhibitor works? I'm trying not to indulge too much for medical background, but just to give you a brief information. So our genomic material is known as DNA, which are the genetic backbone of our genomic information, and that gets translated later to RNA. So the DNA is the base of our genomic information, and they are the basic structure, and they are double-strand sugar backbone with nucleic acid. So you can see there is adenosine, guanine, thymine that help connect these. And those nucleic acid sits in the middle that bind to each other. The damage can occur to either one or both strands of those DNA. And that DNA damage would trigger, usually in healthy cells, a repair process or cell death if the defect is not there, is unrepairable. So constantly cells have damage because of environmental factors or other factors, and then they will trigger a repair process. And if patients or if the cells unable to repair itself, then it will trigger as programmed cell death. So how do they DNA normally repair? So the cells regularly have DNA damage for varying reasons, like exposure to sunlight, other toxins, insults. Normally, PARP would bind to sites of a single-stranded DNA damage and keep the DNA stable. That would allow for other DNA repair molecules to bind and repair that site that has been damaged in the cells, and that keeps the cells going. So if there is a mutation in the DNA damage repair response, so this usually in brief is called DDR pathway mutations. So if there's a mutation on that pathway that disrupts the cell ability to repair genetic damage, which would lead to genomic instability, so the cells become unstable. And such mutations have been strongly linked to development and progression of several cancers, including prostate cancer, and also have a significant implication for cancer therapy. So increased genomic instability, which translates to faulty DNA repair, would allow the accumulation of mutations. So by adding more mutations in cancer cells, that would fuel tumor evolution, and eventually malignancy would develop and progress. So this would create a therapeutic opportunity, which would mean synthetic lethality for those. So in some cases, a DDR mutation can make cancer cell highly dependent on alternative repair pathways because the DNA damage repair pathway is blocked. And in doing so, if we inhibit those compensatory pathways, this would lead to a synthetic lethality or double lethality, where the cancer cells would die, but the normal cells would survive. And an example of this is using PARP inhibitor to treat cancers, especially with specific mutations in the genome, which are called BRCA1, BRCA2 mutations. So what are the PARP inhibitors? They are, as Brad mentioned, PARP, polyadenosine diphosphate ripose polymerase, or in short, poly-ADP ripose polymerase. These PARPs would help repair DNA breaks, single strand, which will allow the cells for survival. So PARP inhibitor would prevent this PARP from repairing the breaks in the DNA, which then forces the cells to rely on other repair mechanism in the DNA. So PARP inhibitor would bind to PARPs, so they will not be able to act on sites of DNA damage. If there is a lack of PARP activity, this means that the single strand damage cannot be repaired. And when this happens, then the DNA is going to be vulnerable to further insults, and double-stranded breaks are inevitable to happen over time. So double-stranded DNA breaks are usually repaired in a different way through the BRCA system, among other systems. So in normal cells, the double-strand repair would fill the gap in both strands and would use recombination repair to restore the DNA back to its normal state. So even if we have PARP inhibitors present in normal cells, they would be still a repair in the DNA damage. So in cancer cells, genes that are involved in double-strand repairs are sometimes mutated, and that's a characteristic of cancer cells. And these mutations would prevent the repair mechanism that usually happens in normal cells. So when we add PARP inhibitors, and those PARP inhibitors go into the cells that have those specific mutations, both a single strand and the double strand repair mechanism would fall. And that would force the cell to rely on other mechanisms. And cells would be unable to repair themselves, and eventually cell death would initiate and kill cancer cells. So potentially, PARP inhibitors would work with other cancer therapies. That's the way the clinical trials and the science is moving forward. So how do we look at PARP inhibitors to selectively affect cancer cells? So if cells have a specific mutation in the DDR pathways, they are now less tolerant to DNA damage, and they don't have any repair mechanisms. So unaccumulated damage in these cells would have the potential to render cancer tumor cells death. And usually the single strand breaks are extremely common. Usually occurs in every 1 to 2 seconds in cell. So when these single strand breaks accumulate, then eventually become double strand breaks. Cancer cells with impaired double strand repair pathways and PARP inhibitors cannot repair the double strand breaks, and these cells would then release proteins which would activate the apoptosis. The apoptosis is the programmed cell death, so each cell would eventually go into a programmed death and die. So it's a controlled cell death. So for PARP inhibitors to selectively affect, how do they selectively affect cancer cells? So it's known that cancer cells have more mutations than normal cells. And those mutations are more frequent in double-strand repair genes, so they're not able to repair. So if you have BRCA and other mutations, those would cause genomic instability in these cells, so the cells become more unstable. And this would cause cancer and eventually initiate cancer and cancer progress. And this can also be caused by genetic instability in cancer cells. So as you can see here, genomic instability of cancer cells would also increase the likelihood of DNA damage, causing more cell death. And there are several mechanisms for cancer to get promoted and get progression. So you have tumor promoting inflammation. They can invade the immune cells. So if your normal immune cells try to kill them, they have mechanisms to escape that mechanism and escape the immunological response from your body to affect cancer death. They can also become insensitive to anti-growth signals. They can also become self-sufficient in promoting their own growth signals as well. They can also trigger programming energy metabolism, so they have their own metabolism independent. They also look at sustained angiogenesis, so creating new vessels to feed them and make them grow more. And then eventually they could invade tissue and metastasize. So PARP inhibitor usually would affect cancer cells primarily by focusing on the genomic instability trait of these cancer cells. This means it's not like a definite treatment. They just try and work around the genomic instability of those cancer cells to promote cell death. So those other mechanisms that is highlighted are what usually the cancer cells try now to evade this genomic instability and overcome PARP inhibitor to be able to continue growing. So how can we make PARP inhibitors more effective for prostate cancer cells and in general? So usually PARP inhibitors would be selective for cancer cells and to promote cell death through apoptosis. So to trigger programmed cell death for those cancer cells, especially those ones that have the mutation in the DDR pathway. So some cancer cells would potentially evolve these mechanisms, avoid apoptosis, and PARP inhibitor would be less effective in those cells. So currently, clinicians are looking at a combination therapies that may help overcome this compensatory mechanisms of cancer cells by targeting other key features of cancer cells to elicit cell death. So for example, PARP inhibitor have been included in clinical trials with the androgen signaling pathway inhibition. So if you work in synergy by giving AR, which is the AR blockage, which is the main treatment for prostate cancer. So you take out the hormonal stimulation, those cancer cells, so they become less able to progress. And then by adding PARP inhibitor, this would have a synergy effect and would be able to even work more to decrease disease progression. And that treatment especially would be beneficial in patients where they have BRCA mutations primarily. So PARP inhibitor would synergize with this anti-androgen blockade because the anti-androgen would inhibit cell growth while PARP inhibitors would kill the existing cells. The androgen targeting would limit the gene expression of prostate cancer cells and that therefore prevent the work around PARP inhibitor. So PARP inhibitor would block the DNA activity of the androgen-related proteins and eventually reduce gene expression further. So potential synergies would be to add PARP inhibitor to other treatments such as immune checkpoint inhibitor like PD-L1 targeted therapy or AKT pathway inhibitor, or to add it to radioligand therapy as well. So those are like PSMA targeted therapy in prostate cancer because prostate cancer is known to release PSMA. So adding those treatments along with PARP inhibitor would have potentially more effect in killing cancer cells while potentially sparing some of the normal cells. Now, all of these treatments are typically not yet combined with PARP inhibitors. However, they are looking at it to start adding those in clinical trials and assessing if combination of those therapies would actually have more power in killing tumor cells while potentially sparing side effects. And as I mentioned before, PARP inhibitor are not specific treatment only for prostate cancer. So what other cancers these PARP inhibitor can be used for? They can be used for breast cancer, prostate, ovarian and fallopian tube cancers. They'll also be used for pancreatic cancer and some gynecological cancers like endometrial cancer as well. So all of these tumors potentially share the presence of DDR pathway mutations. And because of that, then PARP inhibitor can be an effective treatment for all of those cancers where they have the mutations. And potentially, they could also be effective even if there is no mutations in these pathways. So, because it appears that not all patients with the mutations would respond equally, and some patients without a mutation, they may also respond. So current research now is looking at how can we more predict the response of those PARP inhibitors with or without mutations, because potentially those mutations may not be the sole predictor of PARP inhibitor response. But in general, PARP inhibitors would be effective for cancers which have high rate of homologous recombination deficiency, or HRD, which essentially means the inability to perform the double-strand repair. So for example, you have BRCA1, BRCA2, ATM mutations. In cancers, then they will be more vulnerable for PARP inhibitor. So PARP inhibitors are approved in ovarian and fallopian tube and gynecological cancers for patients with recurrence regardless of their BRCA status, and also as a later treatment option for those with BRCA mutations as well, or HRD pathway mutations. However, in breast, prostate, and pancreatic cancers, PARP inhibitors are approved for metastatic cases or samples that have known existence of BRCA mutations. They are not seen to be effective yet in patients who do not have those mutations. Now, if we just look at PARP inhibitors in itself, they are relatively safe drugs because they more selectively targeting cancer cells while sparing normal cells. So they are relatively safe, but there are some serious side effects that would warrant monitoring, although they are rare. These would include pneumonitis, so air in the lungs, myelodysplastic syndrome, so ineffective blood production, like blood cells production, and potentially rare hematological complications, which could be also severe, like anemia, decreased platelet counts, or thrombocytopenia, or decreased white cell counts, which is leukopenia. So patients taking PARP inhibitors may feel fatigue, may also lose some appetite to eating. They may develop nausea, vomiting, or also constipation. Anemia would manifest by being dizzy, fatigue, difficulty breathing, feeling lightheadedness. Neutropenia would manifest by having more prone to infectious etiologies or infectious organisms. So patients may feel feverish and may have immune compromise as well. And thrombocytopenia, which are decreasing in platelet counts, may manifest in easy bruising or bleeding in such patients. Now, those side effects would vary incidentally by the type of malignancy and by the specific PARP inhibitor that is being used, because there are different classes or drugs of PARP inhibitors. The benefits of taking PARP inhibitors would be that they are relatively easy drug to be taken. So you take 1 or 2 tablets per day, and you usually just do a regular blood work to check out blood counts, which would help monitor if patients are developing any of those side effects like neutropenia or thrombocytopenia or anemia. And currently, PARP inhibitors, specifically for prostate cancer in Alberta, are only approved for patients with metastatic prostate cancer who have BRCA1 mutations. So olaparib is the drug being approved for those with BRCA1, BRCA2, or ATM mutational pathways, and rucaparib is only approved for BRCA mutations in those patients. And other PARP inhibitors like niraparib is approved for ovarian, fallopian tube malignancies and gynecological malignancies, talazoparib for breast cancer, and niraparib as well for breast cancer. And olaparib and rucaparib are also approved for other cancers like pancreatic cancers as well. So in summary, if we just, in general, non-medical terminology, if we say who should get PARP inhibitor, where do you think PARP inhibitor would be beneficial? So we know that it's going to be more beneficial for patients with BRCA1, BRCA2, or ATM mutations. But how can regular patients potentially help clinicians investigate if a patient would actually have potentially BRCA mutations in their cancers? So usually we assess whether there has been a family history of prostate cancer relative to the patients, especially developed at young age, so let's say 50 or younger, if there are more than one family member with prostate cancer. Also, if there's a history of breast cancer or ovarian cancer in any siblings or female relative of prostate cancer patients, this may trigger that potentially there's a BRCA mutations in the family. So just to reiterate the issue of those mutations can happen either as a somatic or a germline. So somatic mutations are mutations happening only in cancer cells, but are not present in the normal cells of the patients. But germline mutations, which means that those mutations are present in both cancer cells and normal cells as well. And because they are in the normal cells, they are considered to be a germline mutation. So they have the potential of passing down to other family members to like offsprings of that patients. So it is important when a diagnosis of BRCA mutations confirmed in cancer cell of a patient that they being evaluated by a geneticist so they can assess whether there is an increased risk of that patient having a BRCA mutation in the germline, and that would trigger investigation in other family members to assess if there's a mutations in their normal cells as well. And that usually happens through blood work. Because if there is a mutation in those genes in the normal cells, that would make the patients, not the current patients, but like the offsprings or the siblings at higher risk of developing prostate cancer, breast cancer, or ovarian cancers at later stage in their lives. And we as pathologists as well noticed that the incidence of BRCA mutations or ATA mutations are increased in a specific morphological features of prostate cancer. So often if prostate cancer have a cribriform morphology or have a ductal morphology, that would increase the risk of potentially having these mutations up to 50% of those cancers. Just a general reconfirmation, PARP inhibitors are relatively safe drugs. They're easy to be used. You can take it at home, and you just need to have testing and monitoring of these drugs to make sure that you don't develop any of these rare side effects, and they can be investigated, and treatment can be initiated as well alongside the PARP inhibitor to improve response rates. So I would like to acknowledge Arjuni Savaratam, the director of the medical operation at the Prostate Center, for her support in getting these lectures and the support to present information about PARP inhibitors. So there'll be a series of lectures for medical professions as well and public to make them aware of PARP inhibitor and the use of PARP inhibitors in prostate cancer treatment, and also for Caden, who's a medical student at the University of Calgary, for helping put these slides together. And thank you for your attention. Let me know if you have any questions.
I recently started on, and I hope I'm pronouncing it right, talzopera, so Talzana, which you commented was not currently as covered by AHS. So it's currently self-funded. And wondering if you have any commentary on the potential of it becoming a treatment that is indeed recognized and funded for prostate cancer in Alberta.
Yeah, so I don't know the exact regulatory effects or process for AHS to approve drugs. But I don't know, like, do you know like why they put you on that drug versus the other drugs?
The ATM mutation. So it's in combination with enzalutamide. And we looked at several options of different, and there were other PARP inhibitors too, but it was felt with ATM that this was showed promise.
Yeah, so I think one of the issues is that AHS or the health bodies usually are a little bit behind in terms of looking at data, and they wait for clinical trials to show benefit for specific drugs, even though that they are from the same class. I believe that it should happen, but I don't know like the time lag for those.
Understood. Just looking for a general, and I mean.
Yeah, but these drugs.
Yeah.
Yeah, but these drugs are known to benefit ATM mutations, and in fact, we're just doing some research in Alberta population here, and we seem to actually find that there is more likely there's higher incidence of ATM mutations in Alberta population as compared to BRCA1 and BRCA2 mutations. So I hope these drugs would actually become much available and approved for not just BRCA1, BRCA2 mutations, but for any DDR pathway mutations as well.
I'm just wondering, how do you know if the PARP inhibitor will work for you? Do you do a blood test to find out what the mutation is, or how do they figure that out?
Yes, so initially, I mean, the confirmatory test would be to use a genomic test on, let's say, like, so there's two scenarios. One, if the patient already have cancer, like prostate or ovarian, breast. So if he already developed cancer, they will take sample of the cancer and do a genomic test and identify the presence of these mutations in the cancer sample. And at that time, you will know that, yes, drugs would be effective. If the patient does not have, or if the person does not have cancer yet, but they want to know if they have a risk of those mutations because of family history, let's say like the dad, the mom has one of those cancers, they could do a blood test and they could identify if a mutation is present in their normal cells that would make them susceptible to potentially future development of these cancers. And they could also, if the tumor sample is present from the parent or the sibling, they could also test that. So in order for someone to have a germline mutation, which means the normal cell would have those mutations, the cancer cell, if the patient have cancer, it will need to have those mutations first. So you can predict or work around like the algorithm of testing. If there's cancer sample, you test the cancer sample first. If there's a mutation in the cancer cell, then you look at the normal cell. And if there's no mutation in the cancer cell, this means there would be no mutations in the normal cell. So you cannot have a normal cell mutation in the normal cells if the cancer cell doesn't have a mutation for those individuals with cancer.
Is genomic testing just a simple lab test, or is that something different?
Yes, so it depends. Like I'm saying, if there's a cancer sample, they could do a cancer test on the sample, a lab test, and they can confirm if a mutation is present or not. If the patient can also have a blood test genomically, so the same test, but it's done on the blood cells rather than the cancer cell, and then that would identify if a mutation in the normal cells is present. And if it is present in normal cells, it will automatically be present in the cancer cell as well.
Okay, thanks.
And that would
Yeah.
be separate gene testing that they would do, is that correct?
Yes, so APL currently has that test performed in-house.
Yeah.
So if there's a concern, you talk to your clinician and they would order the test. As I mentioned, currently the funding is approved for patients with, for example, like in prostate cancer specifically, is only available for patients with advanced metastatic prostate cancer. However, through the Prostate Center, we have some programs that we are working on to test patients. For example, if patients are on active surveillance or patients who have do not have metastasis now, but they potentially are concerned that they may have a mutation because their tumor morphology is that of cribriform or ductal, or they have family history of young individuals with cancer or other cancers. Please talk to your clinician, to your urologist at the Prostate Center, because we have some support available to potentially perform these tests free of charge.
Now, down the road, do you see this as being something as part of the pathology for a biopsy, say? If you do the biopsy and you find the cancer, would it be just a natural progression to do the gene test at that time?
I believe, yes. This is what I'm trying to work on, among others, is to try and now predict, based on the morphology of the tumor, the likelihood that that tumor would have a mutation in the DDR pathway. So, for example, I mean, I know it's off topic here, but we're doing a study, or we did a study where we looked at, so the rate of those mutations is about 30% in the more advanced stage, and they're lower in the localized stage. When we looked at the localized stage, we selected those tumors with the morphology that I alluded to, like the cribriform, the ductal morphology. And we found that 30% of those are actually having same mutations as the more metastatic disease. So potentially with more advanced features, we are hoping that any biopsy now that we see would potentially be subjected to those testing because of the benefit of the drug for those patients who have mutations in their tumor.
Excellent. Now, I think we have an online question.
Yeah, the question says, I've seen different methodologies used to characterize cancer extent. Some pathologists calculate the percentage of cores with cancer, while others calculate the cancer volume in prostate cancer sample. Yes, so the volume of the cancer in the biopsies predict potentially the progression rate of the disease. So obviously, the more cancer in the biopsy, the more likelihood there is cancer in the gland itself. And so when a patient is diagnosed with cancer, often pathologists report the biopsy findings in terms of the number of cores being involved with cancer, the percentage of cancer in each of the cores, the Gleason score, if there's a cribriform morphology or ductal morphology. All these parameters would give an indication to the clinicians potentially what would be the best option to treat that patient. So usually if the volume is not too high, if there is no significant pattern 4 recognized or cribriform, patients may be offered active surveillance if they choose to, which means the active monitoring of the cancer without actually actively doing surgery or radiotherapy. In certain times where the volume is higher, there's more likelihood to be offered either surgery or radiotherapy treatments. So those measurements that we calculate usually just give an indication for the physicians and the patients how much tumor potentially you are looking at in the gland, but that the volume itself does not predict the presence of mutations or not, but the morphology, like a cribriform, ductal, or intraductal carcinoma, could potentially predict the likelihood that those tumors would have mutations.
And do you see then machine learning or AI helping the pathologist in those diagnoses, or?
Yes, Brad. So
We'll never replace you, I know that, but.
So currently, actually, I recently received the grant from the Alberta government to look at AI or machine learning algorithm that is based solely on the histological slides of the patient's material that we get to try and predict the potential of those samples or patients to progress. So mainly what we're focusing on in this is the active surveillance. As you know, in active surveillance, patients are usually subjected to yearly biopsy and yearly monitoring. So because we know that there's this situation, like having a yearly biopsy, is uncomfortable. Patients are usually anxious because you're just monitoring the disease. There's a likelihood that you have a progression, and some patients may be afraid that they're losing the curative window. The side effects of the biopsy itself, like bleeding, hospitalization, infections. So we're trying to predict, or we're trying to see if we can predict the rate of progression and the speed of progression from the initial biopsy. So then we can spare patients the need to have repeated biopsy on a yearly basis. So the hope is that we can say to patients based on the first biopsy, you have very high chance that you may not progress within the next 5 years. So you can skip the yearly biopsy and come back in 5 years. Or on the opposite side, if we see that the patient have a more propensity to progress, we say, okay, we think that the tumor may progress faster, so we're gonna monitor you more frequently, or maybe offer you a better therapy rather than active surveillance.
Now, I know we're probably a study or two away from having or introducing PARP inhibitors early in the treatment plan. But I would hope that that would be a goal eventually. First, get them approved for a standard of care, and then look at here, how come if we introduce the PARP inhibitors sooner, are we looking then at better outcomes?
Yes, so that's definitely the way the pharma company are looking into, is to be able to offer those drugs at an earlier stage because of the benefit and the synergy with the androgen blockade therapies, and especially for patients with those mutations. So I believe there are currently looking at trying to understand and show that these drugs would benefit if they're being used earlier and earlier in the disease process.
Well done. See, I read a little bit, had tons of questions. Now they're answered. How good is that? Any more questions? Yes, David.
Tarek, can you, I know you're involved in the 40-year-old PSA study. Can you comment on what's happening there? A few of us here host on demand then, so it'd be helpful if we can have a bit of background on that.
So what we're trying to understand is to see if there is a benefit of doing a PSA screening in younger men between the age of 40 and 50, because currently PSA testing in Alberta is only approved for men with 50 years of age and above. So similar to breast cancer for mammography, they did a study and they found that doing an earlier mammography would benefit identifying patients who would develop breast cancer at a later stage. So currently what we're doing is there's two kind of arms of this study. One, we are looking at the previous PSA data that we had from the ManVan from, I believe, 2011 until now, to see how many of those men fall within the 40 to 50 years of age, what happened to them if they had PSA elevation, what was the biopsy findings, what was the outcome of if they had one, and the current research study, which prospectively collecting data on men with between the ages of 40 and 50 and testing them for PSA. They're going to see how many of those had first one PSA high and then a second PSA high, and then hopefully follow up those patients also with their outcome for biopsies. So the idea is, do we see benefit of advocating to decrease the age at which time patients would benefit from PSA screening? And it may not be for everybody, but it may be, for example, well, we're looking at if there's a family history or if there's something that would allow us to predict that those patients are at higher risk, so then we can offer them an early test.
So gene testing would help.
Eventually, gene testing would help. We're starting with PSA, and then gene testing would help potentially.
Yeah.
Yes.
Yeah.
Tarek, do you have numbers as to how many had elevated of those that have signed up for the study already?
Based on the previous 10 years that we collected, only about 1.5% would actually have two elevated PSA.
Okay.
So the numbers are very low, which is encouraging. Hopefully that we're not missing hopefully significant cancers, and we are looking at now at those numbers from the last 10 years, the 1.5, that patients who had two elevated PSA. Now we are going to go and see how many patients had biopsies and how many patients of those who had biopsies had positive biopsies, and then what happens to those positive biopsies, like what type of cancers they have, what stage they have, did they progress, did not progress, and hopefully we'll try and finalize this study and see if we need to have a support group to recommend to the government to whether decrease the age at which PSA testing is offered or not.
And that current data has just been collected for just over a year, if I recall correctly. July 24.
Yes.
Yeah.
Yes, we just submitted it to AHS to get the data collected from them, the outcome data, and I'm hoping within the next couple of months we'll get that data. So if people interested, the prostate is interested, I'll be happy to come back in a few months maybe and present some outcome data on these.
There you go. So we're going to hold you accountable for that.
Sure.
You know us.
Yep.
That's it for questions. Oh, thank you so much. We've again learned more than we knew when we came in, and that's always a goal. So you've achieved that goal. And we want to thank you for your time this evening. We really do appreciate your busy schedule and you making time for us.
Thank you, Brad. It's always a pleasure to present to the group, and hopefully we'll keep presenting and we'll update the group on more exciting news, hopefully to bring this disease under control.
We hope so.